From Redfield Medical Direction, I am Lin Nguyen, Associate Medical Director, and this is your EMS Protocol Review. Today, we're going to be reviewing a high-stakes EMS presentation, altered mental status. I want to reframe how we commonly think about AMS. By the end of this, I want everyone to understand altered mental status is not a disease, but rather a symptom, and the differential diagnoses are extensive. As one of the most common calls we run, altered mental status is one of the most dangerous because the causes can range from something completely reversible or something immediately life-threatening. And, of course, a lot of the time, the patient can't tell you what's happening. And that's okay. Our job in the field isn't always to identify the exact cause. We just need to quickly identify and treat any immediate life threats. Altered mental status is defined as a change in a person's level of consciousness or cognitive function. Consciousness itself has two major components. The first is arousal, which is how awake the patient is. Can they be awakened? Can they stay awake? Are they unresponsive? Arousal is controlled in the brainstem, and if the brainstem is compromised in any way, like with a stroke, patients can decompensate quickly, usually from airway and breathing problems. The second is content, which describes how well the brain is working. The patient may be awake, eyes wide open, but confused, aphasic, hallucinating, inattentive, or behaving strangely. Content problems point more toward cortical issues, stroke, infection, metabolic derangements, and intoxications. When we assess AMS, we are determining what specific deficits are present, alteration in alertness, content, or both, and the timing of those deficits. This distinction matters because it prioritizes your actions. At bedside, you should be distinguishing the source of altered mental status within seconds of your initial assessment. Can the patient respond to voice and maintain eye contact? Are they protecting their airway? If there's a failure in arousal, you shouldn't be wasting time debating the cause. You need to address the immediate physiology. If there's a failure in content, you should still move quickly, but you usually have time to risk stratify and choose the right transport destination. Everything starts with the basics. ABCs always come first. For most altered patients, airway protection is the first real decision point. An unresponsive or poorly responsive patient may not be protecting their airway, and that alone might be the explanation for the altered mental status. Hypoxia can cause AMS, worsen AMS, or be caused by AMS. You don't need to know which one it is to fix it. In selected patients, non-invasive ventilation like CPAP or BiPAP can help, but only if they can protect their airway and cooperate. That requires constant reassessment. If cooperation fades or mental status worsens, you need to be more aggressive with ventilation. This is where end-tidal CO2 becomes critical. End-tidal CO2 tells you in real time whether ventilation is actually working. A rising end-tidal in an altered patient should immediately make you think hypoventilation and CO2 retention. A sudden drop in end-tidal should make you worried about worsening perfusion and impending shock. Pulse oximetry tells you about oxygen saturation. Capnography tells you about ventilation and perfusion. They are not interchangeable. Once airway and breathing are addressed, vital signs become your next diagnostic tool, so don't forget to take a temp and reassess the pulse and blood pressure often. Abnormalities here may point to shock, dysrhythmias, sepsis, or environmental emergencies. Hyper and hypothermia are not secondary findings. They are life threats that require immediate action. Every altered patient gets a glucose check. Test before you treat. The ancient practice of blindly pushing D50 has been shown to be unnecessary and potentially harmful. If hypoglycemia is confirmed, treat it and reassess. Mental status usually improves within minutes. Opioid overdose is another common reversible cause. Narcan works, and a titrated approach aimed at improving respirations, not full arousal, is usually the safest strategy. Synthetic opioids may require repeated dosing, so reassessment is important. Between oxygen, ventilation, glucose correction, Narcan, and seizure control, you can reverse a lot of altered mental status cases before you even know the final diagnosis. One of the most dangerous assumptions we make is labeling someone as just drunk. Alcohol intoxication should always be a diagnosis of exclusion, not a shortcut. Alcohol increases the risk of trauma, hypoglycemia, liver failure, infection, seizures, hypothermia, hypoxia, and intracranial hemorrhage. Altered mental status can be the primary presentation of other critical conditions. An inferior MI with hypotension may show up as confusion because the brain isn't getting enough blood. A stroke with aphasia may look like any generalized altered patient. That's why time-critical causes must always stay on your radar. Stroke screening should be routine in altered patients, and large vessel occlusion scales help determine where the patient needs to go to get the proper definitive treatment. The appropriate approach to altered mental status prioritizes rapid and thorough assessment, supports vital functions, corrects reversible conditions in the field, and maintains a high index of suspicion for multiple possible underlying contributors. And that's all we have for this episode. This is a production of Redfield Medical Direction. This episode was produced by me, Lin Win. The theme music is by Infraction. As always, don't hesitate to reach out if you have any questions. See you next time.